Hello and welcome everybody to the MinADM data release part 2. I'd like to introduce Dr. Jennifer Hall-Lande, who is the PI on the MinADM project. Jen?
Good morning, everyone, or good afternoon, I should say. Thank you, Libby, for that nice introduction. And I want to second the welcome to everyone. We are so happy to have you here today for part 2 of our MinADM, and I'll be using the term ADM, which stands for Autism Developmental Disabilities Monitoring Network data release. Next slide, please. All right, so as I said, welcome again. Today is our second in a webinar series talking about our ADM data. Today is going to be focused a lot on our Minnesota numbers, which I know all of you are excited to hear. First, I'm going to start with a quick overview of national numbers. If you were on part 1, you've heard it before. I will try and keep it interesting, and I will be very brief. And then next, we'll have Dr. Amy Essler, my co-PI, do new data on Minnesota communities. That'll be new and exciting. And then we'll answer questions at the end. So welcome, and I'll just do a quick overview. Next slide. So just a quick overview in terms of what the ADM network does. It's a long and well-established network that looks at autism prevalence. It's really the largest ongoing tracking system. They've been tracking since study year 2000, and it tells us a lot of things. A lot of what we know about children with autism prevalence comes from ADM data. So it helps describe the population of children with autism in select communities in the United States. It compares how common autism is in different parts of the country. It helps us better understand age of identification if we're getting to kids early enough. And it helps identify trends in autism and autism characteristics over time. Next slide, please. Many of you have seen this before, and we'll talk about this a little more. Many people think that ADM network sites are in every state. No, they're in select states. In fact, 11 communities. We're lucky that Minnesota is one of them, as is our neighbor in Wisconsin. We're going to talk a little bit more later how we need to think about that when interpreting the data, as well as it's somewhat of a limitation of our data set. But again, we're very happy to be part of this network. Next slide. So previous, just a little bit about our methodology. One strength that we feel that ADM brings, one of many, is that we collect very comprehensive data around autism and autism prevalence. We collect data on autism diagnosis and identification in both schools and clinics. So we're able to capture where kids are served, where they're getting identified. Again, some sites just do clinical data. We do both clinical and school. And so we really get a nice sampling of what autism looks like in Minnesota. Step 2, our data abstractors review records, collect data. Step 3, scientists here at the University of Minnesota, epidemiologists, and those on the research team analyze the information. And step 4 is what we're doing today. We share the findings with the community. And if I could add a step 5, I would say we get feedback from the community about what they're seeing, what's of interest to them, what trends they're seeing, and that helps further inform the work that we do. Next slide. So today we're going to talk a lot about prevalence. Those of you on this meeting likely have heard this many times before, but the way we look at prevalence, and we look at 8-year-olds and 4-year-olds, I need to update my slide here. But the numerator here, number of 8-year-olds and 4-year-olds with autism. Our denominator is the total number of 8-year-olds and also 4-year-olds within that area. And that's how we get prevalence. We're going to talk a lot about prevalence today, so it's just a nice way to sort of frame it. Next slide. So here is the numbers from the National ADM Network. What we have found is what the ADM Network reported, 1 in 44, these are 8-year-old children were identified with autism in the ADM Network. That is those select communities in the ADM Network. That comes out to and if we look at it as a percentage, about 2.3%. And what we talk about is no longer can we consider autism a low incidence disability. It's much more common than what many might think. And if you think of the average 3rd grade classroom, 8-year-olds, likely there's going to be a child with autism. And so these numbers support that, what we're seeing out in the community. Next slide. Here's a slide, and we're going to talk a little more later about interpreting ADAM data, but it's showing trends over time. Like we've said, the ADAM data is the longest autism tracking in terms of prevalence, and they've been doing it since study year 2000. Back then, they were finding prevalence rates around 1 in 150. We're seeing these every 2 years of data collected. Our most recent is study year 2018, even though we're reporting this in 2022, and we're seeing 1 in 44. We want to be careful because when we look at 1 in 44 compared to 1 in 54, you might say, oh, wow, that's a big jump. A couple things to consider. The methodology changed, and Dr. Essler is going to talk a little bit about that later on in her slide. And also communities within the ADAM network change, and that certainly does affect our overall number. So again, Dr. Essler is going to talk about that, but this is the trend we're seeing every 2 years when we collect ADAM data. Next slide. Again, here's a slide many of you have seen before with the CDC data. What we're seeing is boys, based on our data, were about 4.2 times more likely to be identified with autism than girls when we look at all the ADAM sites. Interesting, when you look across autism research, that's a pretty consistent stat that we see. A paper came out in the Journal of Autism and Developmental Disabilities today, looking at global prevalence, and they saw something similar in terms of those numbers. Admittedly, it was a systematic review, so ADAM data went into that likely, but we are seeing this as a pretty robust number. That said, we get a lot of questions. We can talk more, are we missing girls? Are we not? But this is what we see when we come in and count. Next slide. Another area that we've looked at is not just gender, which you're seeing, this is what we call a box and whisker plot. Certainly, we're seeing a difference in prevalence with gender, but one area we've seen that we've done better is across cultural and racial groups. We're doing better in terms of prevalence. It used to be we were seeing disparities, and we felt that we were missing a lot of kids. While we still have a lot of work ahead of us and a ways to go in addressing disparities, we're seeing, from a statistical standpoint, looking at the ADAM data, not the significant differences we used to see. It is progress. Next slide. Again, a slide we're all familiar with. Looking at children identified with autism, we used to view it as co-occurring with intellectual disability long ago. Now we're seeing that when we look at stats, that about 65% of children with autism identified in the ADAM network had an IQ greater than 70. And so that's interesting when we think about implications for school programming, waiver-based services that really, if we're looking at population right now of 8-year-olds within this data set, most do not have a co-occurring intellectual disability. Next slide. We also looked at 4-year-olds, and that was something new this year that our MinADAM team offered. What we're seeing in our 4-year-olds is a rate of 1 in 59 within the ADAM network, and that's about 1.7%. Next slide. Additionally, across the ADAM network, one number we look and it gets a lot of attention, and I do a lot of work in early identification and early intervention. Across the ADAM network sites, we were seeing an age of identification for clinical diagnosis about 50 months, or look at that as 4 years, 2 months. Slowly, we're making progress in that area in a national sense. We'd like to see it even better. We know, and many of you have heard me say this before, if clinicians have proper training and experience and are using the right tools, we can identify children with autism relatively reliably between 18 months and 24 months. So we still have a long ways to go in terms of reaching that. Of the children identified with autism, about 47% had an evaluation recorded by age 36 months. Next slide. So one question, and I'm not going to cover the Minnesota data, that's going to be Dr. Essler, but when we look across the network, we do see some sites are getting to kids earlier than others. California, who was new to the ADAM network, and again, when we think about prevalence rates, back to that slide with the map on it, one thing you also need to consider is there was significant variability in prevalence rates across the state. California, I believe, is a number of 1 in 26 in terms of autism. So they're identifying more kids, and they're identifying kids earlier. So if we look at California, and again, it's just in this pocket down here, They're identifying kids on average around 36 months, around 3 years of age. If we compare that to Minnesota, and Dr. Amy Essler is going to share more about that, we're looking at 63 months, much later. And so, of course, it begs the question when we look at national data. Next slide. What does California have that Minnesota doesn't have? What are they doing from a policy standpoint that we could do? Well, we know there's some things that are different. Obviously, California has beautiful ocean sunsets, better weather or warmer weather. But what else, what else are they doing differently? They have a lot going for them in the climate department, but they're also doing well in terms of early identification. Couple things. The area that the data was collected was an urban area with a close proximity to clinical services and a university program. What the research tells us is that we do see where kids have greater access to services and supports when they're near urban areas with a higher density in clinicians, near university centers. They do have better access, and that does contribute to higher prevalence, hopefully earlier identification, but we do have that in Minnesota. California also has regional assessment centers to help determine eligibility for autism. That seems to be very effective in getting kids identified and screened early. Another, and I certainly will share, I need to add it to the presentation, they have an intervention program there where they've trained hundreds of pediatricians they've identified that as a key touch point in terms of getting kids referred early, getting kids screened, getting kids referred early. It's called the Get Set Early model. I talked to the principal investigator of that. I think she said she has, I need to check the stats, but she said, I think she's done over 150,000 screenings with this program through pediatricians. I need to double check that number, but they've gotten to a lot of kids. They've trained a lot of pediatricians on early signs of ASD. They have a network of pediatricians working together. They do a lot of training on early identification, and they do a lot of screenings. And so I would say that is one component that California has, that they're getting to kids, at least in the area that was looked at in the ADAM surveillance within California. These combined factors really are helping them get to kids much earlier. Again, if we're thinking of things we might try and implement in our state, obviously there's likely many other factors, but those were some that we identified. Next slide. All right, but there is some hopeful news in terms of age of identification. One thing that we wanted to look at was cumulative incidence, the rate of identification over time. Now that we have 4-year-old data and 8-year-old data, we want to look, are we getting to these 4-year-olds earlier? And the answer is yes. 4-year-olds in the national ADAM data, they had a higher cumulative incidence than 8-year-olds. I'm going to explain that, meaning that their autism identification is happening in the younger age group, our younger cohort, earlier than in the older age group. So in the US, when we look at our last study year, 2018, when we compare 4-year-olds to 8-year-olds, 4-year-olds were identified at about 1.6 times the rate of 8-year-olds. And so we're getting better at getting to kids earlier. It's happening slowly, but there are, when we look at the data in a different way, it tells a little more of a hopeful story. I'm going to look at these national across cumulative incidence. Next slide, please. So when we take a look, these are all the states, again, 11 states in the ADAM network. We've got the total in the bottom right-hand corner. Again, we're seeing California up here. Really, that's the 4-year-olds are the yellow line. The 8-year-olds are the blue line. If you're in the room, you would see me pointing. We're also seeing a similar trend in Minnesota that we're getting better at identifying 4-year-olds earlier. They were much more likely to be identified than the 8-year-olds in that cohort. So slowly but surely, we are making progress in the area. We still have a ways to go. Next slide. And with that, I'm going to turn it over to my colleague, Dr. Amy Essler.
Hello, everyone. Thanks, Dr. Hall-Lande. I'm going to talk about our Minnesota-specific data, and I'll probably refer back to what Dr. Hall-Lande just went over in a couple of spots. But just to give everybody the background, you've probably heard this a couple of times if you've been to our previous presentations, but we always want to acknowledge how we got here in Minnesota and recognize that The reason we're even studying prevalence in Minnesota is due to the work of grassroots efforts by families of kids with autism, in particularly Somali families who were concerned that they were maybe seeing higher rates of autism in their communities than in other racial and ethnic communities in Minnesota. And due to those concerns, we were able to access funds from different national funding organizations to keep looking at this work. The first study was a local study funded by the state that looked at autism prevalence based only on educational data from the preschool programs that serve autism in Minneapolis. And that expanded to look at citywide Minneapolis in prevalence in 7 to 9-year-olds, where we found similar rates of autism between Somali and white children, but very high rates of intellectual disability among Somali children with autism. Because of that good hard work, we became part of the CDC's ADM network starting in 2015 and have been able to continue this work in a more widespread, systematic way. Our goals in MinADM are to identify, they're the same, the first few goals here are the same as all of the sites in the CDC prevalence study. We're looking at autism prevalence. We're looking at prevalence across race, ethnicity. We're describing what autism looks like in our communities and across race, ethnicity, gender. And then we use the findings to plan and improve services and to identify improvement steps in our communities. As the overall ADM rates don't represent every state in the country, each state's autism rates usually represent just a small part of the state. So you saw California, the San Diego area is what's included. In Minnesota, we include geographic areas within Hennepin County, Ramsey County, and Anoka counties. And it's parts of those 3 counties, including Minneapolis in 2018. We, again, looked at prevalence among 4-year-olds and 8-year-olds who were 4 and 8 during that calendar year of 2018. And in Minnesota, we specifically pull out data on Somali and Hmong children. And those are our communities of interest in Minnesota. And I want to go back to an earlier slide really quick and just talk a little bit about how we define, come on, stay put. Okay, there we go. How we define autism, because this was a change in methodology from the last time we presented these statistics. In the past, you might remember, we determined prevalence through a really deep review of medical and educational records. So we both tracked how many kids had a formal diagnosis or special education eligibility of autism, but then we also reviewed the files to identify documentation that would support a diagnosis of autism, even if it hadn't been formally given yet. That was the old methodology. The new methodology only focuses on children who've been formally identified with autism, and they can meet that case definition in 3 ways. Either they have a report that we're able to look at where a professional has documented a written diagnosis of autism, or a special education report that also documents that the child met special education eligibility for ASD, or we can see in the record that there's a billing code for ASD. So one of the ICD 9 or 10 codes, which if you work in a clinic, you know exactly what I'm talking about. But it's just another way to document that a service was received for a diagnosis of autism. So those are the 3 ways, and I'll refer back to that when we talk about ways to interpret this data. Okay, so looking at our 8-year-olds in Minnesota, in our geographic areas of Minnesota, here is our denominator. So these are the kids who were included in our geographic areas. And we broke this down by race and ethnicity. So we had just over 50% of the kids in our geographic area were white, 20% were non-Hispanic and non-Somali Black, 14% Hispanic, about 8% Asian, and then And then we had 515 Somali children, 291 Hmong children, and 201 American Indian. Our prevalence, if we aggregate across all of our county areas, was 1 in 36 children. And this is the 8-year-old data, which is about 2.8%. And so this is new data that we wanted to show you today. We broke this down by race ethnicity, including looking separately at Somali children. We wanted to also present data on Hmong children, and we did have 291 Hmong children in the denominator, but we did not have adequate case numbers. So we didn't identify enough Hmong kids with autism in our geographic area to really have reliable rates for them. So we can't show their overall prevalence this year. If we look across these different racial and ethnic groups, I should say too, this non-Hispanic Asian Pacific Islander group includes the Hmong children in it. We didn't pull them out separately. So if you look across these different racial and ethnic groups, you can see here are the prevalence estimates, and they vary to some extent. But you can also see that in some groups we had really small numbers. So we only identified among 8-year-olds, 18 Somali children with autism, 14 Asian children, 26 Hispanic. And so these confidence intervals are really important to look at. What they tell you is that it's a 95% level of confidence that the true prevalence rate falls between those numbers. So the overall is a pretty tight estimate. It's within, 6.5 points, right? But if we go down and look at Hispanic or Somali or Asian, it's a very wide range. So prevalence could be as low as, looking at the non-Hispanic Asian Pacific Islander group, it could be as low as 13.6 in 1,000. It could be as high as 33.7. So that's a wide range. And it just tells you that some of these estimates aren't very precise. The next slide breaks it down in a little bit different way. So we compared statistically the prevalence to see if they were significantly different. NS here means they were not. Really, we look at statistical significance as a p-value less than 0.05. So this one is approaching significance. We did see a higher rate of autism among our Somali students compared to Hispanic students. So the prevalence ratio was 1.9, so 1.9 Somali children with autism for every 1 Hispanic child. And the other one that was significant is Hispanic compared to non-Hispanic, non-Somali Black. So they had a lower prevalence rate compared to that group. We did not see differences in any of these other comparisons. So comparing Somali children to non-Hispanic white or to non-Somali Black children. We also looked at the male-female prevalence breakdown. It was exactly the same as the national breakdown when we look across all groups in Minnesota. So boys were 4.2 times more likely to be identified with autism than girls. And then we looked at that by race ethnicity as well. So this first half is looking at the males separately from the females, and we could only include racial and ethnic groups where we had enough females in the autism group. So you can see these groups below didn't have as many, they had lower female case numbers, females with autism, so we couldn't calculate their prevalence. But what this is showing is in each of the groups where we had enough females to look at, we did see significant differences in prevalence between girls and boys. And it was a little bit different based on the group. White children, it was 5.3 times as many boys as girls, 3.1 for non-Hispanic, non-Somali Black. But again, these are low numbers, so probably not very precise estimates, as you can see by the range. We also looked at children who have co-occurring intellectual disability in Minnesota. And you can see we had pretty good intellectual disability data, or IQ, I should say, IQ data from our sample. 81% of the children that we identified with autism did have an IQ score somewhere in their records. And of those, 29% had an IQ less than 70, which is our our proxy for estimating the number of kids with intellectual disability. And this was similar to our previous rounds of Minnesota data, where we are consistently seeing between 25% and 30% with intellectual disability. And then this breaks it down by race and ethnicity. And in the 8-year-old group, we were missing actually a lot of IQ data for our Somali children. 44% of the Somali 8-year-olds were missing IQ scores in their records, which meant that fewer than 10 of them fell into the intellectual disability category. So that's too few to really run the analyses. So you won't see them here, but we did not see, this is kind of the comparison, the total sample. We did not see differences in the proportion of children with autism who had intellectual disability by sex. But we did see it by race. So the non-Hispanic, non-Somali Black children had a higher proportion with co-occurring intellectual disability compared to white children. That is one area of disparity that we see, and actually that's reflected in the addm-wide network of 11 states, that for some reason, there is a higher proportion of children with intellectual disability with their autism among Black students compared to white and Hispanic. Dr. Hall-Lande mentioned our median age of diagnosis, and this is clinical diagnosis. Our median age of clinical diagnosis is 63 months, and we are actually the latest median age of diagnosis of all 11 sites. Minnesota was dead last. And we had only about 45% who had a recorded evaluation of any kind prior to 36 months of age. Breaking that down a little bit further, we looked at median age by sex and by race ethnicity for the groups that we had enough numbers for. And we can see that, and these aren't statistically significant because of low numbers. Somali children may be getting identified a little bit earlier, if that's a true reflection of the population, but everybody else is pretty much above 60 months, which is age 5. As we said earlier, it's a little bit more hopeful looking at this cumulative incidence data, which again tells you how quickly kids are being identified. And this is the national rate. And this little line here tells you that we are identifying the 4-year-old cohort. We're identifying children in that cohort at a faster rate than in the 8-year-olds. And in Minnesota, that was also the case. So the 4-year-olds were identified at 1.8 times the rate of the 8-year-olds. So that's a helpful way to look at this, because when we look at median age, we're also capturing kids who weren't identified until 8 years of age, and they're mixed in with the kids who are identified at 18 months of age, 18 to 24 being the window when we can really reliably diagnose this. But this is looking at how quickly they're getting identified. Okay. Oops. Then looking again at the 4-year-olds, here's our denominator. Very similar race and ethnicity breakdown as the 8-year-olds. And our rate in Minnesota was 1 in 44, or 2.3%. This is all of the kids grouped together in Minnesota. And then this is those numbers broken down by race and ethnicity. Again, we didn't have enough Hmong children with autism to include their prevalence rate. So this shows you, again, you can look at this prevalence estimate number and be wowed by it, but then please also examine the confidence interval, because it could be that, I'm going to pick out the Somali group, that their prevalence rate could be 33 in 1,000, or it could be 70 in 1,000, which is quite a big difference. At the overall level, it's only, like a 5-point difference. And then looking at the prevalence ratios, we are seeing some significant differences across the racial and ethnic groups, where we're seeing the Somali children have a higher prevalence rate among the 4-year-olds than white children, and then non-Somali Black children, as well as Hispanic children. And then we're also seeing Hispanic children having a higher prevalence or it's actually a trend. It's not below 0.05 than white children. So some differences by race, ethnicity here. But again, take it with a grain of salt because of our low sample sizes. We did have enough IQ data for Somali children to include them in our 4-year-old data on co-occurring intellectual disability. And traditionally, we are seeing higher proportions of kids with intellectual disability the younger you get, because that often is, a concern that leads to a referral. So it's a pretty common trend to see that the children who are identified earlier also have, more global developmental delays, greater proportion have IQs under 70. And that's what we see in this group too. So we have, actually this should say less than or equal to 70. We have, these proportions. We also had a lot higher levels of missing IQ data than you saw for the 8-year-olds. There are a lot of little kids who aren't getting IQ tests given to them, even though that is a really important component of an autism evaluation. If we take out the missing data, what we see is that if we just look at the proportions with intellectual disability scores, it's about, for males, for the total population, it's about 57%, same for males, females 56%. Non-Hispanic white children, it's about 37% versus 69% for non-Hispanic, non-Somali Black children, and 72% for Hispanic children. We saw of the children who had IQ scores who were Somali, 95% of them. So I think all but 2 had IQs under 70. So we are seeing a pattern still of our kids who weren't white having higher rates of intellectual disability. So our study has some important limitations that we always are careful to point out. First, our geographic area. We can't generalize to the entire state of Minnesota, and we can't generalize to any subpopulation. We're looking at parts of 3 different counties, and the geographic area is actually defined by the school districts who participate. So we're really looking at school district regions within Hennepin, Anoka, and Ramsey County, and only those that agreed to be in our study. So some of the districts that we didn't have participating probably had, higher numbers of Hmong kids participating, or, non-Hmong Asian kids participating. And so we didn't get as close an estimate of those kids this time. So geographic area is a really big factor in looking at prevalence over time. We talked about certain groups having pretty small numbers, which means that our estimates are just less precise. And we're only looking at 4 and 8-year-olds, not all age groups. So we can't tell you how many adults have autism based on our data, which we know is a question of interest for a lot of people. And just to dig a little bit more into how to interpret this data appropriately, I threw in some statements here of things that people often say, like you'll see this in the media, you see it everywhere, that aren't quite accurate. So saying prevalence is on the rise since 2016, or prevalence is up over 20%, isn't quite true, because we changed the methodology and we included some different states this year. And not to pick on California, but they had a 4% rate of autism, and we've never had a state with a rate of autism that high. So if you just look at the overall numbers and say, oh, 1 in 44, that's a huge jump, you have to say, well, it's higher than the estimate that we provided in 2016, but there were different regions involved and there was different methodologies, so they're not directly comparable. Also saying 1 in 44 US children have autism. I mean, I'm sure I've been guilty of saying that because it's shorthand, but really that data is from 11 communities in the US. And within each of those communities, the prevalence ranged a lot. So Missouri, which doesn't usually include educational data, had a very low prevalence rate. And again, California, 3.9%. saying our median age of diagnosis data does look pretty grim in Minnesota, but that doesn't mean we haven't made progress. It's that cumulative incidence graph that tells a more optimistic story, and that we are identifying a lot of kids earlier than we used to, which will help. We also continue to diagnose people well into childhood and adulthood, which, you could argue is a problem because we really want to identify kids early. So if they're struggling in areas of development or behavior, we can help them out with that before, some difficult patterns become established, or before they have to lose out on things like community activities, inclusion in community activities, and the general education setting. We're doing a better job at early intervention to prevent some of those cascading effects. But it's probably the case that there are a lot of people who, have confusing diagnoses, diagnostic presentations, or they don't have a lot of needs until adolescence or adulthood. So we still need to have those services available for identifying them once it does seem like the symptoms are causing functional difficulty. Or it's also not accurate to say, hey, we're great now. We're identifying Black children and white children at similar rates, and that disparity is, we can check that box. Several states, again, it varied by state, several states still showed a lower prevalence for Hispanic children in particular. And then we're still seeing those differences in the proportion of Black children who have co-occurring intellectual disability. Our data can't tell us why we're still seeing those trends. It does highlight the trends though, and hopefully gives us all a job to do to figure out why that's happening. Is it bias in testing? Is it bias in how clinicians and their willingness to identify intellectual disability or to assume it's intellectual disability? Is it that maybe prevalence of autism is even higher in some of the groups with high co-occurring intellectual disability, and we're missing the kids without intellectual disability? Those are all possible things. There are probably other possible explanations that we haven't thought of yet, but we certainly owe it to our populations to be looking at this and scrutinizing it, because it's a troubling trend. We didn't see differences in median age of identification across race, ethnicity at the ADM-wide network. So it shouldn't be that they're missing out on early intervention if those data are true, although maybe it's a piece of differential access to early intervention playing a role. So our next steps are, we're already collecting data on study year 2020. So we'll do this again, looking at 4-year-olds and 8-year-olds. We're always finding resources to expand our geographic scope to try to include a greater number of school districts in each of our counties that we're currently in. We are looking at statewide prevalence in different ways using different data sets. So we might have more on that in the future. And then we always do a site-initiated special analysis, meaning we write a paper specific to our state about things that are important to us. And for us, that's the prevalence and characteristics or co-occurring conditions among Somali and Hmong children with autism. And we did just publish a paper that was looking at Minnesota as well as a couple other states in terms of their age of identification when a child is seen in a health setting versus an education setting. So that was an interesting study that we did that we're happy to talk about at some future date. All right, I'm going to turn it back over to Dr. Hall-Lande to give a little bit more implications of our data.
Thank you, Dr. Essler. All right, well, I'm just going to share a few resources. I've shared them before, but if you thought this was interesting, you can do an even deeper dive just with this link, the ADM Community Report. It'll show you national trends from the 11 sites that comprise the ADM network. You can also look at state by state. So if you're more curious about California and looking at some of their numbers, looking at Missouri, Minnesota's in there, you can sort of see some of that variation across states. So I encourage you to take a look at it. It's a really well done report with a lot of visual infographics that I think really communicate the data beautifully. Next slide, please. please visit our MinADM. So this is our Minnesota ADM site that has a much deeper dive into all of our ADM data as well. You can really get into the weeds of what the Minnesota data look like. And certainly you can follow up with us if you have any questions, and it tells you on there the contact information, but there's really a lot of good data there, more than we could share today. Next slide. And a couple questions that we've been getting, so I thought I would share a little bit. One of the sort of sister projects to our ADM work is our Learn the Signs Act Early. It works really, it focuses on how do we identify kids earlier, how do we empower parents and childcare providers and healthcare providers to understand the signs of really any developmental delay, certainly autism under that umbrella, and how do we get the tools to parents so that they can help navigate the system, have a discussion. Many of you have come to me and asked about the revised developmental milestones. It's gotten a lot of attention in the popular press as well as in academic circles, and those have just been revised in February. And I'm just going to answer a few questions about those because these two projects work hand in hand. Next slide. And this is our tracker app I always promote. So these are the new milestone checklists. They look a little different. Visually, the layout is different. They've spent a lot of time to really make these user-friendly for parents and families so that they can monitor their child's development and act early if there are concerns. A few changes to the milestones that I'm going to talk about today. Next slide. So again, these were revised in February. Obviously, they were working on it for many years. And really, there's been a lot of attention to it. It was a partnership between CDC and the American Academy of Pediatrics. And really, some of the changes, most of the milestones are the same, but there have been some changes that they were hoping made it easier and more accessible for families to track development and to identify delays earlier. So one of the big changes that's gotten a lot of attention, they've changed the threshold for these milestones. Again, these aren't screeners. These are milestones to the age at which they would anticipate 75% of children would be expected to demonstrate the milestone. They really wanted to make it clear to parents and providers that if a child is not exhibiting or demonstrating this milestone, we really need to act. We really need to get a referral. We really need to follow up. They felt that that was clear. They took words out such as warning signs. They wanted also to make things a little more accessible and less wordy so that they were just easy to understand for parents, for families for whom English was not their first language. They got input from families across different cultural and linguistic groups. They wanted to make most of them answered with yes, not yet, or not sure. So to eliminate some of the gray areas. Again, plain language. They reorganized the developmental domains. They eliminated some of the redundancy that was across milestones and then had some open-ended follow-up questions. They also include some more detailed sort of applied strategies for acting early if there are concerns. Again, these are milestones. They really are health communication tools. A lot of the free resources with Act Early are meant to facilitate a discussion between a parent or caregiver and a healthcare provider to really help understand if a child needs additional screening, additional assessment, and to really get them into services as early as possible. You may not be able to see it because I have my background on, but there is an open access. That means anyone can access paper in pediatrics. It's called Evidence-Informed Milestones for Developmental Surveillance Tools. We'll include that when we send out the information, that anyone can read it and it can talk about how these have been revised and sort of the process. So if you're really interested in that, it's about, let's see, I think it's over almost 30 pages. So you can read about that if that's interesting to you. Again, and that's free for anyone to access. Next slide, please. All right, and so these are our citations. We're coming to the end. we certainly said, I need to include some of the additional ones that we included, and Amy, we can include the newly published paper. But this is the paper within the CDC ADAM network that really supplies the national data, as well as on 8-year-olds and 4-year-olds. And I'll include some additional ones, such as the paper that I referenced about the developmental milestones revisions. Next slide, please. And we also want to acknowledge, thank you to all of you for coming. Many of you, if not all of you, are our partners. We have deep gratitude on our MinADAM team. We could not do this without our partnerships from CDC, our state agencies, our educational and clinical data partners. We value the relationship and we appreciate your partnership and appreciate you being here today. Next slide, please. And of course, this is our MinADAM team. You know, you're getting to see Dr. Essler and myself today, but like any project, there are so many people behind the scenes that make it happen. Really, the unsung heroes of any project are usually the people you don't see, the people out collecting data, running analyses, and also Libby, who was here in the beginning, who's our project coordinator, that really just makes sure everything flows so smoothly. We appreciate everyone's contributions, so thank you so much. And with that, I believe we are ready for questions. If we have any. Libby, are you seeing any questions?
Yeah, I think people have to put them in right through chat or through the Q&A. Is that right? Because we're webinar format.
Yeah, that's correct.
Okay.
And if you don't have any now, you can reach out to myself or Dr. Essler or our MinADAM email, and we are happy to answer any of your questions. If you need a little time to think and process, that's absolutely okay. All right, so Libby, it sounds like you're not seeing any questions.
No, I'm not.
All right. Well, thank you again, everyone, for.
There's the chat. Oh, it's a thing.
Thank you. You're welcome, Kim. Thank you. You're welcome. Thank you for coming today. And again, you know how to reach us if you have additional questions, but I do encourage you to take a look at that CDC community report, as well as our MinADAM website, or reach out to any of us. We're happy to answer any of your questions. All right. Thank you. Take care, everyone.